I just want to ask a question too. How many patients were diagnosed with AIH or their variant syndrome or anything else less than 18 years of age? So we actually have quite a substantial amount of patients with that. So the pediatric approach to AIH, I think there are some subtleties, and I think it's important for the whole room to understand, and it gives us more of the understanding of the phenotype. And so that's why we had Dr. Mohammad come and kind of help to explain this, but also particularly just how do we approach pediatrics different? I think it's an important question. So join me in welcoming back Dr. Mohammad.
Absolutely.
Thank you, everybody, for sticking around today. I thought it would be good to give you guys a break before I started, but now I see I stand between you and your FibroScan interpretation. I got to hurry. So I'm going to talk to you a little bit about the pediatric part of autoimmune hepatitis. I think a lot of the speakers have covered some of the slides that I'm going to be showing today. There are some differences. The medications are mostly the same. The newer maybe medications or the experimental stuff always comes to pediatrics a lot later than adults because they have to be cleared by adults before we test in peds. So I'm just going to talk about the overview, pathogenesis, treatment, and then a little bit about cytokines, which is something I'm doing some research in. So it was first described, autoimmune hepatitis was first described in the 50s by Dr. Waldenstrom, who is pictured here. He also put his name to something called Waldenstrom's macroglobulinemia, porphyrias. He described pulmonary hemosiderosis and perineoplastic syndromes. And this comes from his paper where he first talked about autoimmune hepatitis. This is really just showing how much total protein there was, and this was one of the first, this is kind of the poor man's test for when we look at people who have chronic hepatitis, whether they may have autoimmune hepatitis or not. You have higher total protein because there's more, we think of it there being more immunoglobulin, and then you see the albumin levels are here, and then the globulin levels are here. So we think there's more globulin compared to albumin, but overall the total amount of protein is a little bit higher than normal. This obviously is not very sensitive, but it gives you a rough idea when you first see a patient. So there's chronic hepatocellular injury in autoimmune hepatitis. The etiology is not clear. There's a lymphoplasmacytic infiltrate with interface hepatitis. You have high AST, ALT. You have autoantibodies and hypergammaglobulinemia. So this is a global disease. It's rare, as it's been told to you guys before. There's 0.3 to 0.4 cases per 100,000 children. There are more females. It's a cause of chronic liver disease in 10 to 12% of everyone who has chronic liver disease. And it accounts for a small proportion of transplants in Europe and North America. A lot of patients, up to 45%, have some other kind of autoimmune disease. And this includes celiac disease, thyroid disease, IBD, PSC, and it's not something that always is there when you're first diagnosed with autoimmune hepatitis, so it's something that should be checked for periodically. And by periodically, maybe once a year or every 2 years, if you don't have any obvious symptoms. This is just a simplified criteria that you guys have seen before. It's not used by everybody. I think you always have to do a liver biopsy to really look at the liver tissue and decide whether or not this looks like autoimmune hepatitis. So this is a study that came out of Canada that looked at pediatric patients who had autoimmune disease. They had 159 children over the 10-year period in Canada. They calculated an incidence of 0.2, so it's a little bit lower than what's published. The kind of median age was 12 years for type 1 and a little bit younger for type 2. They had cirrhosis in about a fifth of patients, as you guys have heard before. It's not uncommon to have cirrhosis, and 9 of their patients were transplanted. So 4 of the patients died. 2 died post-transplant, 1 died from a lymphoma many years after diagnosis, and 1 from meningococcal meningitis. So this is just a list of all the symptoms that these patients had. I just want to focus on the fatigue, the jaundice, and abdominal pain. So obviously, fatigue is a very nonspecific symptom. It's something that, our kids might say on a daily basis that they have fatigue, but I would say and it's hard to say whether they really have a disease or whether they're just tired, but it's an important thing that we ask and should be asked of patients. Jaundice is usually pretty apparent, and so more cases with cirrhosis would have jaundice at presentation, but not all. And then abdominal pain is another common presentation. So they looked at who had, 120 did not have cirrhosis and 30 did have cirrhosis. And it was kind of evenly split between the type 1, type 2. And seronegative just means they didn't have anti-smooth muscle or anti-LKM. And when you look at, this is obvious, when you look at the albumin is lower in the group that had cirrhosis. The INR or the clotting was worse in those that had cirrhosis. And the platelets were also lower in those that had cirrhosis. So these are some of the tests that we usually do when we first meet somebody who has this disease to try to gauge whether it's been long-standing or if it's something more acute. And with time, if you see something like the albumin going lower or the platelets getting lower, it's a sign that the liver disease may be worsening. So there are many extrahepatic autoimmune diseases. I know a lot of the people here may have had a thyroid disease first and then autoimmune hepatitis, or they may have celiac disease. Other diseases such as vasculitis is possible, diabetes is possible, vitiligo, nephritis. These are all things that kind of come under the same family of autoimmune hepatitis. So type 1 is more common overall, while type 2 is just more common in the youngest of patients, those I would say under 8 years of age. Whenever I see somebody who has type 2, in my mind, I kind of think of them as a little bit harder to treat. And then you've heard of overlap syndrome. So autoimmune liver disease, I would say, are a spectrum consisting of autoimmune hepatitis, PSC, and then PBC. We generally, I've never seen a PBC in somebody under 18. Of course, it's possible, but I usually deal with AIH and PSC, and in children, overlap is present when both of those are present. So this is a little bit of a busy slide, but I'll just show you real quick. This data came out of the King's College in London. They looked at patients who had type 1, type 2, and then this kind of overlap syndrome. More people with bowel disease had overlap syndrome. An abnormal cholangiogram, something that looks like the bile ducts, obviously had a more overlap syndrome because you would see abnormal bile ducts in something like PSC. Smooth muscle antibody, 100% of the autoimmune hepatitis 1s had it. I mean, that's what they used as their diagnostic criteria, so it had to be that way. And then when you look at cirrhosis, fewer patients with overlap syndrome had cirrhosis compared to type 1 or type 2 autoimmune hepatitis. And then I'll say that this overlap syndrome it's hard to define. Not everybody agrees what it is or what it isn't. And it can be something slowly progressive, so you may see some abnormality on one liver biopsy. You may not see it on the next one. You may see some signs on an MRI, and you may not see it on the next one. So it's something that I keep at the back of my mind. I would never say you don't have it now, you're never going to get it. But I've seen it develop slowly with time. And slowly, I mean, in pediatrics, probably over 5 or 6 years. And in adults, it may be even longer. So this is just some of the data on the genetics that you guys have probably heard of. It may be a little bit more common in first-degree relatives. I know Craig said that when he did the survey, it looks like it doesn't, that doesn't pan out. People who have autoantibodies or hypergammaglobulinemia would be more likely to develop it. I was very happy to have the pathologist talk yesterday. I thought that was very useful because I'm always telling the biopsy results either over the phone or in the clinic, and I don't always know kind of how much people know beforehand. This is a normal liver biopsy. You know, all the stuff on the outside are the liver cells, which we think of as important, but as a hepatologist, I'm really focused on this area, which is the portal tract. This is the portal vein, that's the bile duct, and that's the hepatic artery. The bile duct is supposed to look like a rotary telephone. It's not something that the younger people even know what a rotary telephone is, but I think maybe most people here will know what that's supposed to look like, so I got to find a new way to describe it. But see how it's kind of nice and round, and each one of those dots is a cell, just like, you know, a number. And this is the limiting plate. So that's kind of the border between the portal tract and then the kind of the rest of the liver cells. So here we have somebody who has autoimmune hepatitis. So compared to the previous, you can see it's more blue, and like they were saying yesterday, blue is a little bit of like a bad cell. So there's more blue cells here. This stuff is the normal liver. This is the kind of the portal tract where the vein is and the artery is. And this highlights kind of where that inflammation has escaped out of that limiting plate and out into the liver. So these are the little areas that are outside, and this is what's known as interface, because it's at the interface between the portal tract and the liver cells. So and then these are, if you can see, they're surrounded, these are dead liver cells. So these are what probably are giving you the higher ALT and AST. As the liver cells die, they release the enzymes. And they're dying because there's inflammation surrounding them. And then this is the whole picture again. So I like this. This is from my pathologist. He's got a website that has, you know, these pictures on them. And I like how it shows, you know, kind of in stepwise form where we're looking and where the damage is. So if you have a portal tract that does not have this inflammation spilling out of it, when I do another biopsy, that's when I'd consider you'd have liver normal enzymes, you have that, and then I would say you're in remission, and we could, you know, start taking people off of medication. But if inflammation is coming out, then I wouldn't do it. So autoimmune hepatitis, it's rare, it's more common in females, and the presenting symptoms may be vague. It occurs with other autoimmune disorders. You've heard a lot about genetic factors, triggering factors for pathogenesis. This, I'm just going to show, you know, in autoimmune hepatitis and just autoimmune disease in general, we think there's too much of these kind of red stuff, so more inflammation-driven, regular Tregs, cytokines, and what you want to do is kind of cool everything off. So if you can target cytokines that actually reduce inflammation, you may help autoimmune hepatitis as well. And these are some targets that people are looking at. So low dose IL-2, interleukin-2, giving IVIG, and expansion of giving T regulatory cells which help regulate your cytokines may help as well. So pathogenesis is incompletely understood. It may be triggered by infections, and we think that T regulatory cells may play a role. For treatment, you know, I want to say this is one of the studies that looks at the discontinuation of immune suppression in children, similar to what was presented a little bit earlier. You know, they had 56 patients with autoimmune hepatitis, 27, so just more than half achieved biochemical remission. 19 did not have relapse. They attempted withdrawal in 16 and were successful in 14. So it still comes to this, between 20 and 30% of people can come off of medication, whereas the rest probably have to stay on. This is another study that I think I've seen the graphs from a lot of people. I took the graphs out because they look awful. They just don't present well, but the basic thing on there is they had 56 kids and 298 adults. They showed that children are more likely to have relapse. They had an increased requirement for liver transplant and had decreased in their life expectancy. And we don't know if that's because they got diagnosed earlier and are suffering with the disease longer, or it's because did they get diagnosed earlier because their disease is more severe, and are the adults getting diagnosed later because there's something a little bit less severe in their disease course. That's one argument. The other argument that I kind of think of is, I think in kids you may be able to get them off of medication at a higher percentage than adults, and maybe it's something that they can grow out of too. So it may not be such a bad thing to have it as a child as well. So they found poor prognostic factors included very high transaminases, jaundice, coagulopathy, one of these genetic factors, African American males, and having type 2 autoimmune hepatitis. This graph also just shows some things that may make you more likely to respond to treatment and then less likely to respond to treatment. So being female, having bridging fibrosis, positive SMA may make you a little bit more likely to respond to treatment. But when we're looking at something that's statistical, you don't want it to cross this number 1. And all of these cross number 1. So you can believe it, but you have to take it with a grain of salt. You can't believe it completely, because there are going to be people who have cirrhosis who respond very well, and there's going to be people who don't have cirrhosis who fail. So what are our treatment endpoints? You want to have disease remission. Another endpoint is relapse after treatment withdrawal. There's people who have incomplete response, treatment failure, drug toxicity. So in remission, I want to see disappearance of symptoms, number 1. 2, I want the ALT and AST to be less than 2 times upper limit of normal, and ideally normal. And I think in pediatrics, we're going with the normal being, in males less than 30 and females maybe less than, I think, 25 or 26. You want the IgG and bilirubin to be normal. No inflammation on a biopsy. And you can get that outcome in 65 to 80% of patients by the time of 3 years, and you have a 10-year survival of 90%. If your enzymes go up all of a sudden, that's what's called a relapse. The IgG may increase, it may not increase, but you will see recurrent inflammation on a liver biopsy. And anyone whose numbers had been normal and then go up 3 or 4 times up is someone who probably should get a biopsy to take a look and see what's going on. There seems to be a very high risk of relapse. It may be due to the fact that people who are on medication feel very well. Adolescents don't like to take medications and may skip doses too, so that may lead to relapse. But even after 1 relapse, the majority of patients do achieve remission again. Now, an incomplete response, I would say, is one of the harder things to treat or to even kind of follow. Now, you have improvements in clinical parameters, but you don't have complete normalization. And if you don't achieve normal numbers within about 3 years, then you're unlikely to really achieve, normal numbers. You may need to stay on both prednisone and azathioprine, or you may need to switch the medication as well. So treatment failures, if there's worsening symptoms or progressive disease on a biopsy, these are signs of liver failure, include jaundice, and you either need to be more aggressive with therapy, or these patients may need a liver transplant. Some of the signs of drug toxicity are diabetes, cytopenia. Azathioprine can induce hepatotoxicity as well. So here are usual therapeutics, steroids and azathioprine. They're nonspecific. They just immune suppress everything. Alternatives are budesonide, Cellcept, cyclosporin, tacrolimus. They're also nonspecific, and so are pan-immune suppressives. Some of the newer drugs, I would say, are still experimental. These ones downregulate inflammatory pathways, so they try to just decrease inflammation. Low-dose IL-2 and IVIG try to act at the cytokine level. And then giving T regulatory cells, which previous speakers have spoken about, are supposed to kind of normalize your T regulatory cells, which are abnormal if you have autoimmune hepatitis. Talking a little bit about budesonide, There's really only one randomized controlled trial on budesonide. There's a lot of case reports of people having used it and it working, and some saying that it doesn't work. This one had 207 patients, and they wanted to see normal AST and ALT without steroid side effects. So they saw 47% achieve this in the budesonide group, and only 18 in the prednisone group. I'd say, one problem with this is if you say you don't want steroid side effects, you're sort of, the people who are on prednisone are going to have steroid side effects, so you're sort of biasing your results there. But even then, they only had biochemical remission in 60% of the budesonide group and 38% of the prednisone group. Most other studies have had much higher levels of remission in the prednisone or budesonide groups. When you look at only the over 18s, it was a little bit higher, but still, I would say still low. Steroid side effects were lower in the budesonide group. That was not unexpected. In the pediatric study, there were 46 patients. 16% achieved remission in budesonide versus 15 in the prednisone, and they had 60% remission, biochemical remission, which is just AST, ALT being normal, in 60%. Now this just shows, NS means not significant. So between the budesonide and prednisone, it was not significant for complete remission, biochemical remission, or even at up to 12 months. So they didn't find a significant difference. When you look at ALT activity, you've got, the darker one is prednisone. It drops a little bit faster, but it was not significant. And you look at the IgG, it also dropped a little bit faster. It was only significant at month 2, but otherwise it didn't really show anything, very different between the two. The only thing that was significant was a weight change difference. So people on prednisone gained weight, while people on budesonide either, their weight did not change as much. This is just to show the emerging interventions that are being thought of, being developed for autoimmune hepatitis and other autoimmune diseases. We've been kind of stuck with the regular Imuran, prednisone, Cellcept, some tacrolimus for a long time, and it's nice to see people trying other medications and looking at other mechanisms as well. So most children respond well to treatment. Steroids and azathioprine are the mainstays, and genetics may play a role in the response. In some patients, you can use budesonide. I'm going to briefly talk about cytokines. These are cell signaling proteins. There are some you've seen in this presentation and others, things called IL-2, IL-10, TNF-alpha. They play a very important role in the body for immune activation as well as growth. And we don't know what they do in chronic diseases. We do know that pro-inflammatory cytokines negatively affect growth. So when you give patients who have chronic inflammation, like patients who have IBD, an anti-TNF-alpha, it improves their growth. And when we've looked at patients who have IBD and healthy patients, when we've looked at their quality of life, now these are patients who are supposedly, they're well controlled, they have no symptoms. When you look at their quality of life, this is lower is worse. So this is their fatigue is 73, and the healthy is 82. So you want to have higher numbers. And we see that despite being on adequate therapy, they still report sort of lower quality of life. And that may be due to cytokines causing some kind of low-grade inflammation, just affecting them in a way that we cannot measure right now or today. We know that pro-inflammatory cytokines also affect behavior and cognition. So having a chronic disease can affect how your kid does at school as well, because it can cause fatigue, decreased stamina, inattention, a little social withdrawal. So all these things are so important in the school setting. So we started looking at some of these cytokines and IGF, which is insulin growth factor, in IBD patients, because it's a lot more common than autoimmune hepatitis. And, we saw that, patient, so this is great, IGF-1 score greater, and this is less. So the green one shows that their cytokine levels were better, and we see that their scores were significantly better on all these quality of life scales. So these are different quality of life scales, and they scored better. And then patients not currently receiving biologic therapy. A lot of the patients who have IBD are getting these biologics, which may skew the results. So we took that out, and we still showed that the patients who had normally had good levels of cytokines reported better quality of life. And despite, both these patients had the same sort of disease, same sort of therapy, the only difference was their IGF levels. And then these are some of the cytokine levels. So you have higher, so IL-10 is sort of a anti-inflammatory cytokine, while these are pro-inflammatory cytokine. You have higher levels of these cytokines, of the bad cytokines, when you have low levels of IGF, which is a growth factor. So this kind of showed that there's maybe some interaction between these two things. And if you can design a drug or an intervention that affects some of these cytokines, then maybe you could improve the quality of life of the patients as well. So they're not well studied in liver disease. We expect them to be elevated despite therapy. So in summary, autoimmune hepatitis is a chronic disease of unknown etiology. We have a lot of extrahepatic diseases. Right now, immune suppression is a mainstay of therapy, but cytokine-directed therapies may improve the outcomes. For pediatrics, therapy is really important for growth. Any chronic inflammation will reduce the growth potential of kids and can delay puberty as well. We need to monitor bone and eye health. These kids are on these medications for, not for 20 or 30 years, but maybe 60 or 70 years. And these drugs may not have been around for that long for us to know what's going to happen, so they need close monitoring. Relapses are common, maybe due to hormonal changes around puberty, maybe due to non-adherence, maybe due to increased risk-taking behaviors. Maybe they won't want to take their medications, or they're experimenting with other drugs. And then the other, I think, critical time is the transition to adult care. In pediatrics, things are a little bit different. The number of patients are probably less than in adults, so we do try and are maybe able to spend more time with the patients. I think we're not as pressed as the adult people to see more. Some of it is a financial thing, but when they do go to the adult care, they've been with us for 10 or 15 years. They do feel a little bit lost. It's like going from a small high school to a big college campus. You don't know where to go, what to do, and some of them do have more flares at that time. And then there's increased stress as well. With that, that's all I have. Thank you so much. Okay.
So Dr. Mohammad probably has to depart here shortly. I wanted to see if there was any maybe more pediatric-related questions that we could funnel.